visit our college, please have a glance of our Sri Vishnu Educational Society. Over to Srikant.
Thank you so much, Srikant, and I would like to thank the today's plenary speaker, Dr. Sunkar Murli. I heartily welcome you or 12 p.m. Midnight there, and still you are able to spare your valuable time. Thank you so much, Murli. And I think I'm very happy to have you today. And I also got the details that you were quite busy with the government duty, and you were really working hard during the survey during this COVID situation at the Michigan. And I think despite of your busy schedule, I thank you so much for sparing your valuable time. And to the viewers, I would like to share you that this is a little deviant from the title of drug discovery. However, the main purpose of taking him into the consideration is that during this COVID situations, the most important topic or the area where we all need more focus is the physiotherapy treatment. As we all know, that these are the frontline workers, apart from the various medical doctors and pharmacists and nurses helping us during this pandemic. And I strongly believe that physiotherapy is a major role which can definitely make the patient to go into an advantage state by simple exercises. And I always say that physiotherapists are that first direct contact. Maybe a doctor may not be touching the patient, but physiotherapy at times may require, but however it is not possible every time, or now we have other techniques also that these doctors can help us in curing the COVID conditions. And the second important thing, the role of physiotherapy is in educating the patient. And I think that is the area where that Dr. Sunkar Murli can really help us in educating us all, although we are not patients, but we don't know, right? Since we did not get tested, right? I think I just got the news couple of minutes back that he also routinely gets tested for COVID testing there in US as a protocol. And to share with you, Dr. Murli, here the situation is really alarming, and there are news which creates a little panic situation, stating that it may toll to 25 crores, that is almost 250 million, if we are not ready with the medicine. So I think as rightly told by many politicians, we have to live with it. However, we have to take the things into control and carry on with our work. And such online platforms is a new avenue for all of us, right? And I think I'm very happy to see that you have spared your time despite of your busy schedule. Thank you so much, Murli, for your valuable time. And I wish that this program can definitely help many of our faculty, students, delegates to ensure that staying at home, right, is simple measures which are need to be taken can definitely help us to make us more healthy and prevent the COVID. So thank you one and all, and over to you, Santosha ma'am.
Now I request Dr. Santhosh to give the brief introduction about Dr. Murali Sunkar.
A very good morning, all of you, to all the participants. I am Dr. Santosha. Let me take this opportunity to introduce Dr. Murali Sunkara sir. He is the Managing Director of Barclay Physical Therapy, Rochester, Michigan. Then he is the owner and a physical therapist with over 16 years of experience. He completed his doctorate of physical therapy from Dominican College, New York. He excels in practicing myosacral therapy, myofascial release techniques, spinal manipulation, and mobilizations. He has expertise in evaluation and treatment of patients with orthopedic and neurological diagnosis, ranging from joint sprains, arthritis, muscle injuries, and post-fracture care to post-surgical rehabilitation, back and neck pains, dizziness, balance deficits, and joint replacements. He is the member of American Physical Therapy Association and Michigan Physical Therapy Association. I request Dr. Murali Sankara sir to start his session. That is the role of physiotherapy in the treatment of COVID-19. Thank you.
Hello, thank you. Thank you all for your wonderful introduction. I'm really glad I'm here. Sharing my thoughts, and I thank Ramesh, Dr. Ramesh, Dr. Vanita and Dr. Santhosh for all their welcome and and giving me opportunity to speak here so that we all can share our thoughts and get going with this pandemic, anyways, I hope everybody is doing well out there, and I know India has a lot of number of coronaviruses that's going around, and it's this is something which is new for everybody, and this is something which is coming like once in 100 years. So some kind of these things we never seen, our generation before had never seen, and I don't know if our generation after will see, but this is something once in 100 years I would think that would come like this. But we had to keep our spirits up and then keep going. That's what I would say. Anyways, my name, like she said, I am a physical therapist from Michigan. And I came from, my hometown is Bhimavaram, and I did my bachelor's in Chennai. And after my bachelor's, I started my practice in Bhimavaram, and I was one of the first physical therapists in West Godavari, the district. And then I somehow went to Canada. I got an immigration to Canada. I immigrated to Canada, and from Canada to Michigan, I started doing my practice in physical therapy. And I'll just interchange. It's physical therapy. We call it as physical therapy in US, and it's physiotherapy in India. So both are the same. I might interchange those words because actually both are same. So that's how the different parts of the world call us. So anyways, and after that, I started practicing, and meanwhile, I did my doctorate in physical therapy in Dominican College in New York. And I'm specialized in manual therapy and spinal mobilizations and vertigo-related cases, where I practice exclusively in my outpatient clinic. So these are the basic things. I'm practicing from last 16 years in US, and these all of these experience and all of these physical therapy we learn every day with new techniques, and we try to keep up our pace with new techniques, so that it's new viruses like coronaviruses are coming, and we have to keep up with all our expertise in all these techniques to get to the point where we are. So anyways, now I'm gonna start the topic, which is like physical therapy role in COVID cases. So let me share my screen here. Give me 1 second. There you go. Okay. So this is actually what we do. All this webinar, whatever I'm saying right now, is basically what we are trained here, or what we do in mostly in our area and in our practice here. How we treat the COVID patients. This is all based on last few months of different kinds of expertise, treatment plans, and all that stuff. So, like how the COVID cases are changing day to day. So, before I start anything, there is a disclaimer I would say. This webinar is intended for education purpose only. This is not how to train inexperienced clinicians or is not an alternative treatment for COVID-19 patients. So this is purely educational purpose. Please follow your healthcare profession's advice for your treatment plans. Repeated PPE training, fit testing, and credentialing within your institution is very vital. That's what I believe. This is just a disclaimer that I just want to make sure that you always follow your doctor's advice, not just following because every patient is different in different ways. Okay, coming to the seminar or coming to the webinar here, what I want to discuss today is like just a brief overview of pathophysiology of COVID-19 and its resultant signs and symptoms, the basics. I know a lot of you might be knowing it, but these are something that we consider as signs and symptoms here. And the other thing I would like to discuss is about screening of patients, how we screen the patients here, and how we screen the household regarding the signs and symptoms of COVID-19. The next one I would like to talk about is infection control ones in the home, including personal protective equipment management, like how you don your gloves or how you put your masks and all that stuff. So, and then intervention monitoring and options in the home for oxygen desaturations. Like these COVID patients, a lot of times has respiratory problems, and then how to cope up with those kind of things and how you monitor at home and stuff like that. That is what I want to focus on too. And the other thing is recognizing and physical therapy managing post-COVID-19 weakness. With patients who has COVID-19 and then who are having trouble with their muscle weakness or their endurance, all these things can be, we'll just briefly discuss and I'll share my opinion. Again, it's a lot of things are happening right now. Like every day we are getting a new data kind of a thing. Sometimes, what we are saying today is not the same tomorrow because this is quite a new virus and there is still a lot of research going on. So I want you guys to be aware of that, and we'll go from there, okay? Okay, so starting from my first slide here, let's see, coronavirus. I'll just go with the pathology, a little bit of pathology on what the virus is like from different sources I got it. COVID-19 is the name of the disease. The name of the disease is COVID-19, and the virus that is causing it is coronavirus. There's one more than one type of coronavirus that is called, this particular type of virus is called SARS-CoV-2. So it's a positive stranded RNA virus with spike of glycoproteins on the envelope that give it a crown-like appearance. If you see the picture on the right side, this is how it appears. That's why the name corona means crown in Latin, and that's how the name comes, like coronavirus. So this looks like a crown. If you see the picture, you can. So the transmission is through respiratory droplets and through coughing and sneezing. That's what we believe right now. So infection is capable of generating an excessive immune response, which is called cytokine storm. This cytokine storm is something like small proteins in the blood that is generating it. This is something that comes with the infection too, like excessive immune response. The other thing is interleukin-6, IL-6, produced by activated leukocytes. So this is in connection to multi-system effects. Like this is what causes these multi-system effects. So this is one thing. And the next one is the major signs and symptoms. If we talk about coronavirus, is typically the signs and symptoms develop after 5 to 6 days after infection. What we see here is also mostly like between, like if somebody is actually contacted a coronavirus patient, it doesn't show up like, like usually the 5th day or 6th day, that's what we believe, like 5th or 6th day, the infection starts. You'll see like at least the mild symptoms or something like it can range up to 1 to 14 days too. That's why we generally say like, like 1 to 14 days of quarantine or something like that, because it has a range of 1 to 14 days. So if you see the percentage, again, these percentages can vary from time to time because it's still active and it's spreading like a wildfire. So what I want to say is these are estimated data collected, but again, it can change. But right now, it looks like the fever is like 87.9%. Like a dry cough, the symptoms with dry cough patients is like 67.7%. Fatigue is like 38.1%. Sputum production is like 33.4%. Shortness of breath is 18.6% of patients has that. Myalgia and arthralgia, like muscle pains and joint pains, is like 14.8%. Sore throat is like 13.9%. And some people just shows like the headache is like 13.6%, chills, nausea, vomiting, nasal congestion, diarrhea, hemoptysis, and conjunctival conditions. So all these symptoms are pretty much thing. According to WHO, the most common symptoms of COVID-19 are fever, dry cough, and tiredness. These are the main three symptoms they're talking about. And other symptoms that are less common or may affect some patients include aches, pains, nasal congestion, headaches, conjunctivitis, sore throat, diarrhea, loss of taste or smell, or a rash on the skin, or discoloration of fingers or toes. These symptoms are usually mild and begin gradually. Some people become infected, but only have very mild symptoms. So like I said, like the symptoms are varying vastly. Like personally, I know like few, like 4 of my known physical therapists that I know very closely got COVID-19, and each of them has, frankly speaking, like they have like different symptoms. Like one has fever is mostly common for a lot of people, but some have nerve pain, muscle pains, and some has just diarrhea and fever, and some has like a skin rashes. So it's so obvious, like like each patient symptoms are differ from patient to patient. So that's why this is not an easy virus, like because like we cannot stick on to particular symptom and say that okay, this is he got these kind of symptoms. Like I know a wife and husband who are infected, and both of them have different symptoms. Same house, same strain of infection for both of them, but still I can see like a lot of different symptoms between both of them. So this is something we should think of, like a lot of diseases and a lot of things that we have a common symptoms, but this is kind of widely spread, and sometimes it's hard to diagnose too. So anyways, let's go to the other slide. So how is the disease presentation? So if you see the disease presentation, it's like mild to moderate is like mostly like 80% of people have mild symptoms to moderate symptoms, 80%, like pneumonia and non-pneumonia kind of symptoms, the severe patients are like more like 13.8%. So with dyspnea, respiratory rate more than 30 per minute, and O2 saturation is less than 93%. So PaO2 plus FiO2 saturation, 50% of lung fill in 24 to 48 hours. So these are more like respiratory symptoms that they have like in 13.8%, and more patients with critical problems are like 6.1%. They can go up to that like respiratory failure, septic shock, multiple organ dysfunction, and there's a lot of variety in there with critical conditions too, like because respiratory shock and septic shocks, like those infections can cause really fatal symptoms. So this is how the disease is presented, in a lot of countries and a lot of COVID patients. Okay, let's go. So the most common thing is, and the most fatal problems is, one of the things is, restrictive lung diseases. So here in pathophysiology, what I want to discuss of COVID-19 is the milder cases are more like a pneumonia kind of symptoms, and the severe cases are what I gone through some studies, and what I referred through some resources is like acute respiratory distress syndrome, ARDS, is more like a severe kind of characteristics we can see in the patients. So so this is like I said, this virus is so new, and the research is still going on. So like every day we get different kinds of data, but but like the COVID-19 in severe cases is not like a typical pneumonia. Like in pneumonia, it's more like an unilateral, it's infected mostly unilaterally, and it's most likely infected to the lung tissue. Starts with it starts with the infection process. That's how it starts, like the pneumonia. But this doesn't look like that in severe cases. It looks like more like an acute respiratory distress syndrome, where the blood is infected, or if the virus gets into the bloodstream. That's what is happening. And this is more like COVID. COVID patients are more likely this acute respiratory distress syndrome. So if you see the picture here, it's mostly infected in the peripheral and the base of the lungs. It's mostly like on the base of the lungs here. So and if you see the alveoli here, this is what it's more. It's not like a typical mucus secretion, but it's more like a fluidity. It's more like leakiness. It's more like peripheral edema. So the alveoli is filled up where the capillary is are attached, and it is more like a fluid thing where it doesn't actually. It's not like a secretion of a mucus, like the sputum or anything. That's why people get like the dry cough, because it's the alveoli. It's just the fluid and the leakage in the bottom of the base of the lung, like that. And sometimes a prone positioning like sleeping on the stomach with patients. Not with every patient, but some patients, they say it's going to help them breathe better. And you see some pictures with prone positioning sometimes in the ICU too. So that's because most of the alveoli or the infected lungs is mostly in the posterior side, and it's in the base of the lungs. So that's what few of the studies saying that. So the characteristics of restrictive lung disease, that is pneumonia or ARDS, mostly it's like a dry, unproductive cough. Like I said, when the alveoli is fluidy and and when there is like edematous tissue underneath the lung, it's mostly non-productive cough. It's not productive cough. So so we can see like low lung volumes, increased respiratory rate, and shortness of breath. These are the characteristics of acute respiratory distress syndrome. Or so this is more like related to COVID, severe COVID cases, like who has respiratory or breathing problems. So the consequences of long-term acute RDIS, is we call it as, is ventilation mismatch. So the oxygen intake and oxygen and the carbon dioxide intake output is very much mismatched. The ventilation is mismatched, and increased work of breathing. That's why people are very hard to breathe, because these alveoli are completely fluidy and they cannot exchange the gases or exchange the oxygen, because they're mostly like edematous. So, and that's how desaturation is formed. So this is something mostly looking at the severe cases kind of thing. So this is how the acute respiratory distress syndrome, this is leading cause of COVID-19 mortality. Subgroup appears to develop a cytokine storm. So this cytokine storm is something like there's a small proteins in the blood. It is called as so there is an increase in increase of these cytokine storm, like proteins in the blood, which the labs can be like increased ESR and ferritin. And corticosteroids might be indicated that can, they say like might be. Again, it's a question mark, but they say like it might be indicated to reduce those symptoms. Then mechanical ventilation, we have to minimize the bar trauma, and moderate to high PEP. So prone position should help. And ECMO is like respiratory equipment we use to ventilate those lungs and stuff like that. So this is something like more related to COVID-19 syndrome symptoms. Then this is the prone positions, what I'm talking about. This optimizes gas exchange and improves oxygenation. You can see, but this is not suitable for all the patients. You know, it can be with ventilated or non-ventilated patients can be positioned. But there is a question like, and then the physical therapist or the physiotherapist or the respiratory therapist usually helps in positioning the patient very carefully. It's a challenging position to place a patient like this, but this is how some patients with some symptoms we believe are showing good effect for the treatment plan. So there are certain in some hospitals we have like the prone teams where there is a team of faculty where the patient is patient is positioned in prone. There's a special teams for that, because this is a very, like I said, very critical thing to do. It's not easy to just you know, because with all the with all the tubes and with all the other extra equipment that's on the body, it's not. Sometimes the patient is in sedation too, because this position is not a very comfortable position for the patient. But sometimes, but this is how they can really breathe good. So so this is one thing they do it in the ICUs. Okay. So talking about this, on June 17th, this is from WHO website. I got this like from June 17th, 2020, excuse me, WHO announced that the hydroxychloroquine arm of the Solidarity trial to find an effective COVID-19 treatment was being stopped. Actually, they stopped it because I think they could not find enough evidence of that it's helping the patients. So when the treatment options right now are remdesivir, lopinavir, ritonavir, and lopinavir and ritonavir with interferon beta LA, 1A, sorry. The treatment options are originally selected based on evidence from laboratory, animal, and clinical studies throughout the world, I guess. So this is from the WHO website. I got this, and this is what I think they're following right now. We don't know like how long this is going to be, and they might change based on different evidences and different researches going on right now. The next thing we would like to talk about is screening of the patients. Here, what we do is the first thing we is like we screen the patients, and we screen the family members and caregivers to know like exactly what they're going through. And the screening questions are mostly like what we ask them is if they have an international travel within last 14 days to countries with sustained community transmission. The next one is like signs or symptoms of any respiratory infection, such as fever, cough, or sore throat. Even in my clinic, what we do is each patient, whenever they come, or every day, even if they come every day, or even if they're doing that, we do the screening. What we call is we have a bunch of questions for them, and then we take the temperature, and then if we have certain guidelines that if the temperature is more than certain point, like 99 or something like that, and then we ask them to go and check for COVID testing and stuff like that, and any other symptoms, like if they have a cough, sore throat, or if they're out of country for before 14 days, like so anything like that, we screen them thoroughly, and then we also ask them if they're coming from any community where the spread is more, it's community-based spread of COVID-19 is occurring or something like that. So there are, based on those responses, we take them and we put them into the categories. If we think like they are more prone to be COVID patients, then we ask them to go for test and see if they can get test done right away and quarantine themselves if there is something going on. But yeah, these are the few screening questions that I would like to share. And again, this is from WHO too. There are different terminologies that we are using around for quarantine, isolation, and physical distancing. So quarantine means restricting activities or separating people who are not ill themselves but may have been exposed to COVID-19. The goal is to prevent spread of the disease at the time when people just develop symptoms. So quarantine is basically, just a kind of a doubt, like, if you're exposed to some people who are, they're not really ill, but, it's good to be on quarantine for 14 days where they might, they're exposed to some kind of a COVID area or something like that. Then isolation means separating people who are ill with symptoms of COVID-19. These are tested positive COVID-19 patients and may be infectious to prevent the spread of the disease. So these are that is isolation. And physical distancing means basically physically apart. WHO recommends keeping at least 1 meter distance from others. This is a general measure that everyone should take, even if they're well with no known exposure to COVID-19. Okay, let's go with the other slide. Okay, infection control practices, education, and patient caregivers. One thing I would like to share is like, like physical therapy wise, or we educate patients a lot, and even the caregivers, like the family, and all this, because this is something that we have to tell the patients what is right and what is the right thing to do, including how to clean the surfaces too, because a lot of times we don't understand, like even the doorknobs can be infectious, can spread the infection very easily, which we really don't realize. So something like that, where we have to be very cautious, and then we try to educate them. Like these are some of the things that we ask them to, we ask them to take a look at it so that they can follow at their home and stuff like that. So first thing is how to clean and disinfect. Wear disposable gloves to clean and disinfect it. Clean surfaces using soap and water. High-touch surfaces, like I told you, tables, doorknobs, light switches, countertops, handles, desks, phones, keyboards, toilets, faucets, sinks, etc., and all that stuff. Clean the area or item with soap and water or other detergent if it is dirty. Then use recommended EPA household disinfectant, follow labeling. So that's what we try to educate people here. Wash hands often with soap and water for 20 seconds. I think a lot of people know that. And hand sanitizers. And avoid touching your eyes, nose, and mouth with unwashed hands. Shared bathroom, and this is something like a lot of people with shared bathroom. Person who is sick should clean and disinfect after each use. I mean, like if a family member has infection and then if he's using the shared bathroom, that's the easy way to pass the virus again. So I always recommend them to, should clean and disinfect it after each use. Food, person sick should not eat with others in house. Trash, dedicated lined trash cans, use gloves when removing, wash hands afterwards. So these are the basics things we recommend them to do in household activities, kinds of stuff. So I just want to review some isolation precautions. Like there are different kinds of precautions. Like when you do like isolation, like the contact precautions are infections, diseases, or germs spread by touching the patients or items in the room. So like these are the contact precautions. Like these are spreaded by contact. Like you touch a person, these can easily spread like the germs. So like these are the examples are MRSA, VRE, diarrheal illness, open wounds, and RSV. And the equipment we use, we ask them to use them with gloves, maybe gown, if the risk of splash or contact. So, and droplet precaution. This is mostly one of the COVID's precaution that we have to take. This is a diseases or germs spread in tiny droplets caused by coughing or sneezing. Examples are like pneumonia, influenza, whooping cough, bacterial meningitis. The PPEs we use is normally gloves, gown, waterproof surgical masks, maybe glasses if the risk of splash to the eyes. I would highly recommend to use glasses if you're nearby any COVID patients or anything, because it can spread through eye too, like I said before. So, and right now COVID patients are also can be like airborne precaution is also a good practice, because diseases are very small germs that are spread through the air from one person to other. These are airborne precautions. So most of them recommend this airborne precaution for COVID too. So examples are like tuberculosis, measles, and chickenpox. The same thing, the gloves, gown, fit tested N95 or higher level respirator. Face shield and goggles and glasses for this one too. So that would help to prevent these kind of. So these are different precautions if people get confused. Contact precautions, droplet precautions, and airborne precautions. So like to know the differences. So that way you know where to use and what to use. So next, COVID-19 is a droplet airborne being treated as an airborne pathology for most of the part, most of the countries and most of the part we are treating as COVID-19 as a droplet and airborne precautions, airborne infections. So it's actually spreaded by droplet contact. However, when patient coughs, sneezes, or exhales, droplets, they go into the air. So that's why we do it as both droplet and airborne spread. So COVID-19 particles can stay in the air for a while. Studies say it hovers around 1 to 3 hours, but that is in closed spaces, and the viral count does decrease the concentration. So usually, though the expelled droplet will land on something, then a person touches that surface and then they touch their face, eyes, or mouth, etc. This can pass to in this manner too. So it's being treated as airborne with regard to PPE. PPE is personal protection equipment, but the patient may not be in a negative pressure room in acute care, obviously won't at home or subacute nursing home facilities and something like that. So contact with patient with COVID-19, when can they go outside, leave the house? So this is like really a gray area. So when we say like contact with the patient, like when we treat a COVID patient, and there is no certain, there is no enough data saying that the patient is completely cured or the patient is completely like the patient cannot pass the COVID coronavirus or something like that. There's no particular time frame for that because we have different approach and different data. But let's go through this. This may vary and change as we learn more about and how long the patient is contagious. This point, there is not just enough data. As I said, there are guidelines for patient going out house or out to discharge use of PPE. If the patient won't be retested, then at a minimum it should be at least 14 days after symptoms first appeared. So the 14 days is very common, and anybody infected, the 14 days of isolation is a must, and at least 72 hours, that is 3 full days of no fever without use of medicine that reduces fevers. The patient will be retested then once they no longer have a fever without the use of medicine that reduces the fevers. So these are different, again, some sources saying like the patient may be carrier for up to 6 to 8 weeks. There's no definite answer for this, but when patient is when the patient is contagious, no longer contagious, the studies show that patient can shed virus for up to 30 days, and then some sources say it's 6 to 8 weeks. So there is no definitive study, but its best practice is to avoid contact and just follow your precautions and be wise to do what is good for you. So exercise tolerance monitoring. This is again a physical therapy kind of a slide because we're not going over a specific exercise, but you can use a judgment. Like patients, what we do is with the everybody has different levels of tolerance with COVID patients. So what we do is we do like a SOB scale, like shortness of breath scale, and then we track the pulse ox, and based on the vitals and the subjective symptoms, that will be our best guide to know where to cut off these exercises, where we can actually keep going with these exercises and stuff like that. So these are some basic guidelines I just want to share with you. So acute care discharge challenges. So what happens is when there is an acute care discharge challenges, when to discharge a patient is like when there is it's really hard to discharge a patient from COVID when there is a high oxygen requirements at rest and oxygen desaturation with activity. So when they're walking and there's oxygen goes down, then it's really hard for us to discharge them because we know that there is not enough oxygen. And thus we anticipate that these patients will be discharged home potentially on high flow rates and are likely to desaturate with functional mobility. So these are the challenges we are facing with COVID patients because the oxygen levels completely fluctuate at times, and the weakness and decrease in functional mobility is part of it too. So. Okay, so why is it important to prevent desaturation? We call it as, I don't have a graph here, but we call it as a oxyhemoglobin desaturation curve. What it does is like that graph allows us, I could not get the picture here, but the difference between what you see in a pulse oximeter, I believe like you probably know what is pulse ox, like we put it to the finger to know the pulse ox. Versus what is really what the oxygen level in the blood. Usually the pulse ox, if it shows 95, usually the real blood in oxygen is around probably 90 or 85 or something like that. So it depends upon the graph. Like, so when the pulse ox is really low, then the oxygen is much lower in the blood. So that there is a graph that shows that's called as oxyhemoglobin desaturation curve. So decreased O2 supply for the heart. What's the ramifications of this desaturation? So decreased oxygen supply for the heart, brain, and working body. So when the oxygen is less, increased respiratory rate, shortness of breath, and decreased activity tolerance. These are all we sometimes find in COVID-19 patients with severe cases. So the other signs are non-verbal signs of potential desaturations: increased respiratory rate, complaints of shortness of breath, difficulty breathing, assuming rescue breathing positions, tripoding. I mean, patients who cannot potentially say, they're hard to breathe, we look for these signs, pursed lip breathing, increasing anxiety. So over recruitment of accessory respiratory muscles. All these signs are people who cannot talk, and then we can just see on, we can actually notice them, their symptoms, and then we know that they're going through this desaturation thing. So how do we manage these desaturation patients is like, especially in therapy wise, we are pacing of activities slow. So if the patient is really desaturated, we give them the pacing. Like if they have to walk for, walk for like 100 feet, we tell them to take breaks, take like 10 feet, take a break, do it again, 10 feet. That's how your endurance develops, so number of repetitions. So energy conservation DME is like, it's an unnecessary energy conservation equipment where you don't really have to, sometimes we have those things that where you don't have to bend and do those things, but you can use those equipment so that you don't lose your energy. You're saving your energy, saving energy. So we have some of the equipment that we give to the patients that can really benefit from this desaturation thing. Four-wheel walkers, walking, shower tubs, selecting appropriate intensity, seated versus standing exercises. Instead of standing exercises, we tell them to do seated exercises and still develop their muscle strength. Utilizing tripod positioning and breathing exercises. Patients should work on this on their own. Usually we teach them some breathing exercises, and they should be working on. I'll talk about the breathing exercises in my next slides, but inspiratory holds, stacked breathing, segmental breathing, paired breathing, switching airway, delivery devices. So all these things are gonna help managing in desaturation. So these are some of the things that I just want to, you guys know also. This is something that it might help. Rehabilitation and infectious diseases. As a movement experts, physical therapists are in a unique position to offer interventions which will improve quality of life and survival of the infection. So there is still recognition of cluster of impairments which compromise the ICU, AWA, and the PIC. These are so like just briefly in summary. I don't know if you're running out of time, but I just want to tell you like two things here is like ICU. There are some ICU related weaknesses that we call it as ICU AW and PICS. We'll go in detail in the other slides, but these are something that after ICU, these are the syndromes that actually weakens the patient's body for a long term. So we try to re-educate those patients too. This is ICU AW, that's what I was talking about, is ICU AW is ICU acquired weakness. How it is like possible clinically detectable muscle weakness is critical ill patients in absence of weakness are caused by factors other than critical illness. So like patients who are in long-term ICU unit, they develop what we call is an acquired weakness. So what happens when their acquired weakness happens is like muscle atrophy, wasting. So the muscles get wasted, the muscle get thinner. There's no strength in the muscle because they're in long term in the bed and they're critical illness myopathy, critical illness polyneuropathy affect to the nerves and the muscles, or a combination of all these factors. High prevalence of ICU AW patients with ARDS due to prolonged periods of bed rest, need for mechanical ventilation and systemic inflammation. So all these patients can get really sick when they're in this so many months of so many days in ICU. So we call it as ICU acquired weakness, and we have a treatment for those patients where we try to improve their muscle strength and even their mental function sometimes. Associated with higher one-year mortality, impaired physical function, and poor health-related quality of life up to 24 months after discharge from the ICU. They can go through all this. So 1 year of mortality, impaired physical function, and poor health-related quality. So risk factors of ICU, more than 200, because like more than 48 hours in mechanical ventilation can lead to ICU AW, prolonged immobility, persistent systemic inflammation, sepsis, multi-organ system failure. So intervention strategies, what we do is for them, we give them specific exercises, adaptive exercise. We do adaptive equipment like energy conservation. Like I said, those energy conservation techniques are something like where we pace those. We try to improve their endurance. Like endurance in the sense like their stamina, to make sure that they get their they get their workout with enough pacing of their activities. Repeated performance of sit to stand, other functional activities to improve motor learning, strength, and confidence performing activities. Patient and family education. Here the family education is very important because they are the ones who stays with the patients and help them get back on their feet again. Focus on coping, prolonged recovery process. So we have some restorative strategies where we ask the patients to follow certain guidelines for the exercises, and that's how they have to improve their exercise to improve strength, function, endurance, balance, And balance is one of the critical things that we do, that the patient would to prevent risk of falls actually. So coordination of resources and advocate team-based care, referred to other specialists, connect with support groups and community-based services. So these are all like we work as a team before we send the patient home, and one of these things are to get the patient get going again. That's what our main goal is. So what is the post intensive care syndrome? Excuse me. So we call it as this is another syndrome from ICU, like patients who are we call it as PICS, post-intensive care syndrome. What happens here is they have muscle weakness, breathing problems, trouble walking, struggling to care for yourself, drive or work. So this is occurred again, same thing, spend time in hospital, intensive care unit or ICU, you may experience problems with your physical abilities or your mental health too, and your cognition too. So all these things can lead to another syndrome called as post-intensive care syndrome. And these are happening with COVID-19 severe patients too. They'll have sometimes they can include mental health problems, like anxiety, depression, and trouble sleeping. Cognitive problems can include difficulty remembering things, trouble concentrating or thinking clearly, difficulty completing tasks. So all these things are again ICU related syndromes. These two syndromes as a physical therapist, we work to get back to their feet again, because they can show a long-term effect in their daily life. So what we do is, as a physical therapist, and mostly in the hospital-based physical therapists, is they have had physical therapy in hospital. Physical therapists also care for patients in inpatient rehabilitation centers. They have some what we call as home health care, where they go to their home and or they go to the outpatient clinics and try to get back their strength. So we give them a plan of care where we put their certain goals where they can reach their prior level of function again. That's the whole goal of getting back on their what you call is their prior level of function. So we do a lot of stretchings, resistance training to improve health, the strength, with some examples of lifting weights and pulling elastic bands and stuff. We encourage a lot of swimming, bicycling and walking, long distance running and balance exercises. So basically we start with based on what the patient tolerance is. If the patient cannot tolerate, we go with low level exercises, and if the patient can tolerate, we go with, but usually it takes anywhere between 6 to 8 weeks. By the time patient knows a considerable change and he thinks like, he's back on track. So to be precise, we have I have like some breathing exercises that I want to talk about, which is very important during this pandemic season, especially with we have one thing called as a there are a few breathing exercises that would really help to expand your lungs and help breathing really good for patients who is suffering from congestion and who are suffering from some phlegm in the or the fluid in the lungs kind of a thing. What we call is called as diaphragmatic breathing. So what you do is you put your one of your hand on your abdomen, the diaphragm here, and what you want to do is you got to breathe in through your nose, and then make sure that you breathe all the way so that you can feel it on your hand, like you're expanding your stomach. This is called diaphragmatic breathing. We do like 1 to 2 minutes per hour with a goal rate of 1 breath every 10 seconds. So So this really helps to expand the lung, especially the base of the lung where the COVID where the COVID fluid, and in extreme cases where the fluid is on the base of the lung, this diaphragmatic breathing would really help to expand those lungs and stuff like that. So the next one is what we call as cup blowing. I don't know if you can see me, but this is take a cup like this, and then all you have to do is blow 3 to 5 seconds like this. And then you have to do like 10 to 15 times, like you're blowing the cup. 10 to 15 times per hour. Or as tolerated. This is called. What happens is when you blow the cup like that, your deoxygenated blood, deoxygenated air comes out, and then the lungs get cleared a little bit. So that's one thing that that would help. And the other thing we call it as a tissue blowing. Like you take a tissue and then try to blow the tissue, something like that. Like that. I don't know if you can see this, but this is how we do. What you do is, again, 3 to 5 seconds you have to blow it, and you do like 10 to 15 times per hour, or as tolerated. This is something that we can practice with patients who have breathing problems. The other one I want to do is, I want to tell you about is mirror huffing. So like what you do is you just get a mirror, and then you know how you make a fog on a mirror. This is what you do. That's what you should do. Like you got to do 10 to 15 breaths per hour, like that. Mirror, we call it as mirror huffing, like that. So So this is something that these are the basic the breathing exercises that you should practice. So the diaphragmatic breathing is very important because it's going to expand your lung when you breathe in. So and like I said, you had to do 1 to 2 minutes per hour when somebody has like some breathing problems, which is going to help tremendously for your lungs. And there are regular exercises. Again, I want to talk about is there are we call it as glute squeezes, that is butt squeezes we call it as, and then quad sets are like knee squeezes, like we put your knee down and push it and hold it for 5 seconds and something like that. I mean, you can check all this, just put these things, and then I'm pretty sure Google will show you all of these. I didn't have, sorry, I didn't have time to put some pictures here, but these are the exercises, the basic exercises for a COVID patient who is coming out, and they could start working on these basic stuff like knee extensions and sitting, like kick your legs front and sit to stand a few times, kind of a thing. And standing hip extension, standing hip abduction, standing hip flexion, and stairs and walking. And do 2 sets of 20 reps 1 to 2 times per day. That's going to help you too. So, and I guess that's it for today. I guess this is what I thought would help you a little bit with what we do with physical therapy here. And then we have these resources from American Physical Therapy Association and acute.pt.org and WHO. So,
yeah. Thank you, sir, for the informative session. So we have questions, sir, from the participants. I go to Rajshekhar. Mr. Rajshekhar, please ask the questions. Sir?
It was a wonderful presentation. Thank you so much for spending your valuable time.
Oh, no problem. I really didn't keep any track of the time. I hope I didn't.
No. It's exactly on time, and everything was very nice. And it's over to Rajshekhar for questions.
Yeah. Thank you, sir. Very good morning, sir.
Good morning.
We have quite number of questions from the participants. Here I go. So the first one goes like this: the specific physiotherapy that can control cytokine storm infecting lungs. Is there any specific physiotherapy that can control cytokine storm infecting lungs?
That's what we're talking about, like a prone positioning. Prone
Okay.
positioning can help.
Yo.
Those things, yeah. Like
Okay.
it's in severe cases again, and it's not for every patient, but those things can help for sure.
Yeah, we have another question on prone posting, sir. So, what's the need? Why the prone side sleeping is required? Why it is important?
Yeah, like I said, like this especially with COVID patients, it's not like a typical pneumonia. It's more like it's in the base of the lung, and it's mostly the peripheral lung fluid that's what is forming there. So a prone position, and it's mostly affected in the posterior side, So the
Okay.
prone position would really help to bring those fluids out.
Okay. Next one, idea about virtual reality in physiotherapy. Idea about virtual reality in physiotherapy. Kindly justify your idea about.
Yeah, personally, I like the personal touch.
Okay.
I'm a manual therapist by profession, and I like a manual touch, and I like to feel the muscle. But this is not something virtual. Like these are unpredicted times, so I don't know what we can do. So if there's something is better than nothing, right? So
yes.
But personally, I like physical contacts. Yeah.
Okay. Next one, should intrapartum fever considered as possible sign for COVID?
I don't know. I don't know.
Next one, yeah. Please.
COVID is changing every day, man. So
yes. Next question as possibility of reinfection for COVID. Is there any possibility for reinfection of COVID?
I'll tell you something. Like one of my colleague who is very well known to me, he had a positive COVID test done like for a week, and then he was quarantined for 14 days. He was fine. He came back. He got a negative test again. He's back to work. He started treating patients, and he was fine. And after 1 week again, they tested because as a protocol, we test like every week, and then he tested positive. So again, he's in quarantine for 14 days. He has absolutely no symptoms. So I don't know. So it's nothing can be ruled out. If people, this is a practical experience. Is very close. A colleague of mine had problem. This is in fact he's right now in quarantine right now. Okay. So this is a second time infected case. So. It's a direct.
Yes. There is lot of risk to directly come in contact with COVID patient. How do you overcome it, and how can you strongly say that you are safe?
That's what I think I told in the webinar too. Like it's not completely safe at any point. Like because we don't have data. Like they're saying 6 to 8 weeks. They're saying 30 weeks you can still shed virus to others. So there is no definite data as of now. But what I would say is you just use our common sense, and we have to make sure that we have to maintain social distances, masks, and just be as hygienic as possible. That's all I can say.
Okay.
At this point, I mean, there's no clear data that when we are safe. I mean, at this point.
Most of them, they're asking at the end if you can explain these breathing exercises. Once again, that will be benefit for the students. That would be a great benefit at the end. And
sure.
Is the same breathing exercises can be practiced in geriatrics and pediatrics?
Yeah, like I said, like based on a condition, you have to do that.
Okay.
Yeah. Again, everybody is not the same. Yeah,
Yeah.
geriatric patients definitely would help. It would help. And these basic exercises we teach for COVID patients here. Some of the COVID patients who are having trouble breathing and stuff. Like I told you, like blowing the cup,
Yes.
blowing the tissues.
Yes.
These are like a diaphragmatic breathing.
Mirror of
I can probably you can give me an email or I'll shoot an email to somebody who can share those exercises. I can actually send them with pictures.
Yeah.
That would, if that helps you.
Yes. To continue with the same area, sir, how about these, the significance of these breathing exercises in other respiratory disorders such as asthma, COPD, and all those pneumonia and so on? How they
Yeah.
can be helpful?
Yeah,
Is
COPD is like an umbrella, like
yeah.
with most of these restricted anything that clears the lungs, like most of these exercises are helpful for a lot of these cases. Like, again, I'm saying, like we have to go with case to case. Some of them cannot tolerate because their lung capacity can be very low, and then we have to start really low and then gradually increase their endurance and gradually increase their lung capacity. But on average, these are the good exercises. Like I said, I can send more exercises through an email or something with proper positioning and proper pictures to one of your staff members or somebody, and then you can spread it out. That will be much better, I think. I'm sorry I don't have pictures because I didn't have time today. Or
Yeah,
2 days this week we are kind of hectic here. So
that's great, sir. And another question: can you give us an update on newborn being tested positive? Was it thought to be transplant central transplantation or postnatal infection?
the newborn, no, I have no
Oh,
idea
it's not.
about that.
Yeah. Maybe it's not appropriate, I think.
I don't.
Another question, sir. Specific symptom that will differentiate whether patient suffering with COVID or pneumonia. Specific symptom.
Yes, the pneumonia, like I said, it's mostly. I think I gave the differences, right? Like,
Yes.
like I don't. I mean, like. The, with pneumonia, it's mostly infected with the lung tissues. That's what we call it as. And both of them have hard time breathing. But ARDS, pneumonia and what did you say? Pneumonia and COVID.
Yeah, pneumonia and COVID.
Yeah, COVID is, I would say COVID is more like a bloodstream. The breathing would be really hard. With pneumonia, I think like with the steroids and with the antibiotics, it can be cured. But with COVID, it's not happening like that. It's not being cured like that. I mean, both of them have breathing problems. Both of them have like similar problems, but this is a little bit more severe than that. Even with the antibiotic, if it's not getting cured, then it's ARDS, like most likely with the COVID kind of symptoms. That's what I would say.
Another question goes like this: what are the discharge challenges as a physiotherapist to improve the patient care?
Discharge challenges?
Yes.
Yeah, that mostly like the endurance, like people tend to like the patients tend to try to do some workout or like try to do some small activities, and they get their oxygen level gets so low, and then it's hard for us to discharge them because they cannot take care of themselves. So those are challenging situations, and it takes a lot of time for us to develop to get them back on their prior level. That's one of the challenges, the oxygen saturation thing.
And lastly, sir, a lot of requests are coming that can you please say something about these breathing exercises once again, if you have some time. Again, that will be to the benefit of the students, for the benefit of students.
Yeah, sure.
Is it
sure.
okay?
Excuse me, sir, to interrupt you. Please stop the sharing, sir. Then you can see the full screen. You can see the full screen.
Maybe.
Oh, you want me to show
That
sharing?
PPT, if you stop sharing, and you can see the breathing. Yes.
Okay. Are you good?
Yeah.
You can see me now.
Yes.
With the full screen. Oh, okay. So do you want me to tell you right now?
Yeah.
Or,
Once. Yeah.
Oh, okay. So the breathing exercises. What I told is about like those 4 exercises. The first thing what I said is diaphragmatic breathing. So what you do is like you put your hands on the stomach like this, and then you can lay on your back. I cannot lay right now, but like you can lay on your back and try to put your even if you can put your legs on the wall. Like I don't know if you can picture that.
Yes.
Put your legs on the wall and then put your hands on the breathing like this, something like this. You feel it. Okay. So like that, and then try to breathe, and then make sure that when you're breathing, you feel the hand that your air is coming at your diaphragm, like by your stomach, like just above your umbilicus, like that. So you have to feel that that thing is expanding like that, and then hold, and then go like that. You can let go with the mouth, and then do the same thing.
Yeah.
So that's one thing. Like at least you have to do like 1 to 2, or you can do like 5 times to like every hour. If people who are having like breathing problems. Yeah. Okay. The other thing I told is to blow the cup. Either you can take a straw, like it's called as purse lip. You can take a straw and blow the cup. Like there's a cup here. So what you're doing is you're blowing it for 3 to 5 seconds. Like that. So like you're actually blowing a cup like 3 to 5 seconds. You're doing for 10 to 15 repetitions. So this is one thing that's going to clear your lungs, like your oxygen levels and stuff like that. So, and the same thing, like you have a tissue or something, and then just blow the tissue like 5 seconds, and then relax. And you can do the same thing for 10 to 15 repetitions. This is the other thing that I was talking about. And what's the other one?
How can you confirm that patient is cured from COVID other than testing negative?
Other than testing negative, I mean, we cannot say anything, because like I said, like patients, like there are so many asymptomatic people that are roaming around. You don't even know that they have COVID.
Yes, exactly.
And then you cannot say like there's no particular scale or anything that can say, like I said, somebody tested negative and he tested positive again next week. So it just happened in front of me. So
yes.
So
this is regarding this. What is the reason of losing of smell, which is called as anosmia, which is anosmia, which is a symptom of COVID? Reason for it?
There's no the symptom. Actually, like I talked to those COVID patients, and they said like sometimes they cannot smell for perfume around, and then it's a strong smell, and somebody beside you can smell, and this guy cannot smell for 2 minutes or 3 minutes. After 3 minutes, he said, "Oh, I'm smelling something," and there is no reason. I mean, no research. They're still researching about it. It's just a symptoms. All we know are symptoms. No, we really don't know the reasons. A lot of these things. Taste and smell is a big thing. It's a big thing. Especially they are developing in second week after the infection. Once the taste and smell are developing, I think the third week will be the recovery phase. That's what is happening.
That's an interesting point to be noted, sir. Yes.
Okay, yeah.
Yeah. With this, I complete, sir. I thank you for the patient hearing and addressing your students' questions and faculty questions. And we have glad and loud to hear you again in future. Thank you.
Sure.
Thanks
sure.
for your time. Yeah.
No problem.
Over to Anta, madam.
Yeah, thank you very much, sir, for your time, for taking the time and for your active participation and showing the how to use this blowing the glass and tissue, everything, sir. Thank you very much, sir. Although it is almost 1:30 for you, late night, even though you are spending a lot of time with us, sir. Within a short period of time, you accepted our invitation, sir. That is a very great thing, sir. Thank you very much, sir, for your active participation.
No problem. I'm off tomorrow, so I'm fine. I'll sleep over. And I should do this for Dr. Ramesh anytime. So
Thank you, Murali, for wonderfully explaining us about the exercises even on live. And I think that is the reason why you were one of the best doctors in Bhimavaram. And now you have set up your own clinics at 2 places in US, and that shows the successful entrepreneurship partnership with you. And thank you so much for your leadership qualities. And we anticipate many more. And if anyone has got any problems, we'll directly dial you for the better treatments also. Right.
Sure. Thank you. No problem. Thanks. Thank you. My pleasure.
Dear participants, thank you for your participations. Tomorrow we have session at 10 o'clock. Thank you. Thank you very much.
I'm hanging up.
Thank you, sir.
Thank you.